Okay, welcome to the deep dive. Today, we're doing something a bit different, really focusing in for your revision. We've got these detailed revision notes here on one specific condition, degenerative cervical myelopathy, or DCM.
That's the plan. We want to take these notes, which, let's be honest, can sometimes feel like just a list of facts, and turn them into a really high-yield overview for you. Think of this as, well, a focused study session to get the key points across.
Exactly, like having a couple of study buddies help you sift through it all. And DCM's important. It's actually pretty common, particularly as we get older, so it's definitely one to understand well.
Absolutely. We'll hit everything: definition, causes, symptoms, how it's managed, pulling out the really crucial bits you need to know.
Right, let's jump straight in then. First up, the definition. What exactly is degenerative cervical myelopathy? Can we break that down?
Okay, so at its core, DCM is progressive. That means it generally worsens over time. It's degenerative, relating to wear and tear, and it specifically hits the cervical spine, your neck. But the key part, it causes compression and critically dysfunction of the spinal cord itself.
So it's not just about neck ache. It's the structures in the neck through wear and tear, physically squeezing the spinal cord running through it. Is that the idea?
That's exactly it. And the notes point to the usual suspects causing this age-related narrowing, degenerative disc disease, the discs drying out, losing height, spinal stenosis, that's the spinal canal itself narrowing, and osteophyte formation, basically, bone spurs.
Right, those bony growths, they all just reduce the space for the spinal cord.
Precisely. Less room for the cord means trouble.
Okay, that definition sets the scene. The what, the where, the how. So what about the why?
Yeah.
What actually causes this degeneration beyond just getting older?
Well, age-related wear and tear is the main driver, like we said. Those changes, the discs, the stenosis, the bone spurs, they happen over years. But the notes also mention other things that can sort of contribute or speed it up.
Right.
Genetics might play a part. Some people seem more predisposed. A history of significant neck injury or trauma is a big one. Damage can definitely accelerate the degenerative process.
Makes sense. An injury could set things off.
Yeah. And interestingly, chronic inflammation is listed too.
Chronic inflammation. How does that fit in with the spine? Seems a bit less direct.
It's maybe less direct than, say, a whiplash injury, but think of inflammation as a background process that can degrade tissues over time. Persistent inflammation might just worsen that degenerative environment within the spine's structures. It's fascinating how all these things, injury, maybe inflammation, genetics, can funnel down to creating that physical squeeze on the cord.
Okay, I see how they connect. So if those are the causes, who's most at risk? And here's where it gets really interesting. Are there lifestyle things involved? Things people do?
Oh, absolutely. Age is number one, typically hitting people hardest between 50 and 70. And yes, past neck trauma is a clear risk factor, but lifestyle, definitely. Smoking, for instance.
Smoking. Right, that one always seems surprising for a neck problem. Why smoking?
Well, smoking messes with blood flow everywhere, including to the intervertebral discs. Less blood flow means they don't get the nutrients they need, they degenerate faster, become less resilient. Basically, it speeds up that wear and tear process that leads to compression.
Wow. Okay, so smoking is a big one to remember for this. What else is on that risk list?
Certain jobs or activities, things involving repetitive neck movements, or spending long hours with your neck bent forward, think text neck, but maybe occupationally. Also, jobs with high axial loading, like heavy lifting, can put extra stress on the cervical spine over time.
So posture and occupation matter too. And genetics, you mentioned that again.
Yes, that underlying predisposition seems to be a recurring theme.
Okay, so we have this degeneration, maybe sped up by smoking or injury, leading to the squeeze. Now, the really crucial bit, how does that physical pressure actually damage the spinal cord? The pathophysiology.
Right, this is the mechanism of injury. The degeneration causes direct mechanical compression, literally squashing the cord. But it's not just the physical pressure. That squeeze also compromises the blood supply to the cord.
Ah, so it's being squashed and starved of oxygen and nutrients.
Exactly. That lack of blood flow is called ischemia. And on top of that, the damage and ischemia trigger an inflammatory response within the cord tissue itself. So it's kind of a triple hit. Mechanical stress, poor blood flow, and inflammation.
And what does that triple hit actually do to the cord tissue?
It leads to actual spinal cord damage. The notes mention things like demyelination, that's damage to the protective coating around nerve fibers, the myelin sheath, also axonal damage hitting the nerve fibers themselves, and generally neuronal dysfunction. Basically, it disrupts the signals traveling up and down the cord.
Okay, so damage to the wiring and the insulation, messing up the messages. That makes sense. Now, for anyone revising, this next bit is always key. It's a differential diagnosis. DCM symptoms can be really sneaky, right? What else could it be mistaken for?
Absolutely crucial. This raises an important question. How do we distinguish DCM from these other possibilities? The symptoms, especially early on, can overlap quite a bit. So you need to think about other things that cause myelopathy. That's any disease affecting the spinal cord, like multiple sclerosis, spinal cord tumors, maybe an acute injury, or even inflammatory conditions like transverse myelitis.
So anything else directly affecting the cord? What about problems lower down, like the nerves coming off the cord?
Yes, that's a big one. Radiculopathy, specifically cervical radiculopathy. That's when a nerve root is compressed as it exits the spine. DCM is cord compression. Radiculopathy is nerve root compression. Symptoms like arm pain or numbness can overlap, so it's a really important distinction.
And the notes even say it gets mixed up with carpal tunnel syndrome sometimes. It's just way down in the wrist.
It really highlights how misleading hand symptoms like numbness or clumsiness can be. They might originate much higher up in the neck. Other things on the list. Maybe simpler causes of neck pain and stiffness, like straightforward cervical spondylosis, although remember, spondylosis is often the cause of DCM or just muscle strains. Even fibromyalgia could present with some overlapping features like pain and stiffness.
Wow. Okay, so a really broad differential from simple strains to MS. You definitely need to keep DCM in mind. Speaking of how common it is, do we know much about the epidemiology, numbers?
The source notes say UK-specific data is a bit limited, but it's definitely considered a common condition overall. And the prevalence clearly increases with age, which fits the degenerative nature.
Any difference between men and women?
It affects both, for sure, but the notes mention a slightly higher incidence in males.
Okay, so let's pull this together with the clinical features. What does someone with DCM actually experience? You mentioned symptoms can be subtle initially.
Yeah, that subtlety is key. It might start as just vague neck pain or stiffness, easily dismissed. But the real telltale signs relate to that cord compression. Think problems in the upper limbs, weakness, numbness, tingling in the arms or hands.
Like difficulty with buttons or handwriting changing.
Exactly. Impaired fine motor skills are classic. Suddenly struggling with tasks you never thought about, buttoning a shirt, using keys, handwriting, becoming clumsy. That's a big red flag. Imagine that sudden difficulty with everyday things.
And it affects more than just the hands, presumably, given it's the spinal cord.
Oh, yes. Because the cord controls everything below the neck, balance and coordination problems are very common. An unsteady gait, difficulty walking, feeling clumsy on your feet, those are major indicators of myelopathy. You might also get sensory loss below the level of the compression.
And in really severe situations.
In more advanced cases, unfortunately, bladder or bowel control can be affected. That signals pretty significant cord dysfunction.
Is there anything specific a clinician looks for on examination? A particular sign?
Yes. The notes specifically flag Hoffman's sign. It's a reflex test. Basically, you flick the patient's middle fingernail, and if their thumb and index finger flex involuntarily, that's a positive Hoffman's. It suggests upper motor neuron pathway damage, like you get with cord compression. It's a really high-yield sign to know for exams.
Okay, so Hoffman sign, key takeaway. So we've got these potentially vague symptoms, neck issues, clumsy hands, balance problems, maybe sensory changes, plus that Hoffman sign. Given the overlap with other conditions, how do you actually confirm it's DCM? What are the investigations?
It always starts with a good clinical evaluation, detailed history, thorough physical and neurological exam looking at strength, sensation, reflexes like Hoffman's, coordination, gait.
But you need to see the problem, right? Imaging must be vital.
Absolutely vital. X-rays might show some degenerative changes like bone spurs or disc space narrowing, but the gold standard investigation, the one you really need if you suspect myelopathy, is a cervical spine MRI.
Why MRI specifically?
Because it shows the soft tissues beautifully. You can directly visualize the spinal cord, see exactly where and how much is being compressed, and crucially, you can often see signal changes within the cord itself, which indicates there's damage or swelling there. MRI is essential.
Makes sense. What about those other tests like EMG? Do they fit in?
EMG and nerve conduction studies look at the peripheral nerves and muscles. They're not the main tests for DCM, but they're really helpful for the differential diagnosis, helping rule out things like radiculopathy or peripheral neuropathies, where the problem is in the nerves after they leave the cord. And, blood tests might be done to rule out other systemic causes, inflammatory conditions, etc.
Right. So clinical picture plus that gold standard MRI confirms it. Once you have the diagnosis, what happens next? How is DCM managed?
It's usually a multidisciplinary effort. The notes stress that urgent referral to specialist spinal services is recommended once DCM is suspected or confirmed. Management then falls into two broad camps: non-surgical and surgical.
Okay, let's take non-surgical first. What's involved there?
This is more about managing symptoms and providing support. So things like physiotherapy, specific exercises, pain relief medications, maybe using assistive devices like walkers, and lifestyle advice like posture improvement. But there's a really important point the notes make about physio.
Oh, was that?
Physiotherapy needs to be guided by specialists who understand DCM. Certain exercises, especially forceful neck movements, could potentially make the cord compression worse, so it needs careful supervision.
That's a critical point. Okay, so careful non-surgical management. When does surgery come into play?
Surgery is generally considered for patients with moderate to severe symptoms or clear evidence of progressive neurological decline. The main aim of surgery is decompression.
Decompression, literally taking the pressure off the cord.
Exactly. Removing whatever is causing the squeeze could be disc material, bone spurs, thickened ligaments. Sometimes they might also do a spinal fusion at the same time to provide stability after they've removed the compressing structures.
And is the surgery generally effective?
The notes highlight that decompressive surgery is really the only treatment that addresses the underlying cause, the compression itself. It's considered the primary effective treatment to halt or slow down further damage to the cord.
You mentioned urgent referral. Is there a time frame for treatment that matters?
Yes, and this is super important, another high-yield point. The notes emphasize early treatment. Ideally, intervention, especially surgery if needed, within about 6 months of symptoms starting gives the best chance of neurological recovery or preventing further decline.
6 months. That's quite a window. Okay, need to remember that. So assuming someone gets treatment, what's the long-term outlook, the prognosis? And what are the potential complications if things don't go well?
The prognosis is really variable. It depends a lot on how severe the cord compression and damage was before treatment, the patient's age and general health, and how quickly they were treated.
So surgery isn't a magic bullet for reversing all the damage.
Not always, no. Surgery aims to stop things getting worse and can often lead to improvement in symptoms. But the notes are clear that if significant cord damage has already occurred, some neurological deficits, weakness, numbness, balance issues might be permanent. It might halt progression, but full reversal isn't guaranteed.
That's important to manage expectations. What are the risks or complications if it progresses or isn't treated effectively?
The complications are basically worsening neurological function. So that could mean progressive loss of motor function, potentially leading to significant disability, persistent or worsening sensory problems like chronic pain or numbness, ongoing bladder or bowel dysfunction, and a really high risk of falls because of the balance and gait problems.
And are there things that help improve the outcome overall?
Yes, definitely. Regular follow-up and monitoring are key to catch any changes. Adhering closely to the recommended treatment, whether that's ongoing therapy or post-surgical rehab, and making those lifestyle adjustments, managing weight, avoiding risky activities, quitting smoking, all contribute to optimizing the long-term outcome. So just to quickly recap those key revision points again. Definition progressive, degenerative compression of the cervical cord. Causes mainly age, but risks like smoking, injury are important. Pathophysiology compression, ischemia, inflammation. Clinical features, think neck pain, clumsy hands, balance issues, gait change, maybe that Hoffman's sign. Investigations, MRI is gold standard. Management, urgent specialist, referral, physio needs care. Decompressive surgery is the main effective treatment. And timing early treatment, ideally within 6 months, is crucial for prognosis.
That's a fantastic summary. It really paints a clear picture of this condition starts subtly, easily missed, but needs quick action.
Precisely. Catching those early, maybe vague signs is so important.
Which leads nicely into our final provocative thought for you, the listener. Given everything we've discussed, how DCM often starts with these nonspecific symptoms like slight hand clumsiness or mild balance issues, how easily it can be mistaken for other things, and yet how vital that early diagnosis and treatment within that 6-month window is to prevent potentially irreversible spinal cord damage. How should this change our approach when we encounter any new unexplained neurological symptom, however minor it seems? Doesn't it argue for a higher index of suspicion? A bit more digging, perhaps, when things just don't quite fit a simple picture?
It really does. It underscores the importance of careful assessment and, well, thinking broadly when faced with neurological complaints.
Absolutely. Something to definitely mull over. And with that, we've navigated these revision notes on degenerative cervical myelopathy. Hopefully this deep dive has made it clearer, more memorable, and high yield for your study. Remember those core concepts we highlighted.
Use this as your launch pad. Build on these key points.
And for more high-yield revision material, do check out pastmsra.com and also freemsra.com. Keep learning, everyone, and keep diving deep.